1, 2, 3.
The game's been good to me, preserved my youth. Not only did it capture my goals, it told me the truth.
Conversate for a few, cause it a few.
I let them know we missing you. The love is unconditional.
Wave your hands, what's the land if we family?
We got a world premiere right here, now get lost.
So off we go, let the trumpets blow. And hold on, because the driver of the mission is a pro.
What's up, everybody? It's your boy MRB, and we want to welcome you to the very first episode of conVersate with Us Radio. Before we get started, let's hear a few words from our sponsors.
He's adding that flavor to your function. DD's Daiquiri.
Good people, good vibe, one drink at a time. Good people, good vibe, one drink at a time.
Flavor to your function. DD's Daiquiri.
Good people, good vibe, one drink at a time. Good people, good vibe, one drink. Wanna kick back, wanna just vibe. Word kick back. Let me first slide to the drink store. Let me just buy DD drink mixes, all of them fire. Fill me up a case, I'm finna drop bread. Marvelous mango, classic and red. Took them to the party, these folks won't leave me alone. They wanting me to share, they better get their own. DD's adding that flavor to your function. DD's Daiquiri. Good vibe, one drink at a time.
So, November is Diabetes Awareness Month. Diabetes is something that has a drastic impact on the Black community, so I felt it was important for us to talk about this topic, and I had to bring in one of the most dopest people I know, an expert on the topic, Dr. Shani Davis. Dr. Davis, how are you?
I'm wonderful, Marvin. Thank you so much for having me.
It's a pleasure. It's a pleasure. So, tell people about yourself. You are the founder and owner of Your Best You Clinic in Tampa, Florida. Tell people about your background and how you started your practice.
Thank you again. Well, my name is Dr. Shani Davis. I am a nurse practitioner, PhD, advanced practice nurse, and certified diabetes care expert. I have been in business on my own for about 6 years. However, I have been a diabetes-focused nurse practitioner for more than 20. Your Best You is a full-service primary care practice, but we have an intense focus on diabetes management. That means use of sensors, insulin pumps, multiple daily injections, including some of the newer injections that are non-insulin in the way they work. We service both insured and uninsured patients. We do cash pay, all of those things, because diabetes is an epidemic. There are lots of people who care. What we do that's different in our office than in a typical primary care office is that we sit back and teach, which is very important when you have diabetes, a chronic disease. There's no cure for chronic disease, so you need to know how to manage your diabetes, your hypertension, your obesity, things that really do have no cure. You need to be able to manage it at home so that every visit to your care provider is a visit that takes you closer and closer to your goals of health. You can live with diabetes. You can live with your heart issues. You can live with obesity and with goals towards managing and obesity reduction. But it doesn't have to be a burden. You can approach that with your healthcare provider, mutually goals set, and success is absolutely possible in all of these things.
So, a question that I have, a lot of people talk about how sugar, I used to call it the sugar, how diabetes just runs in families. The question is diabetes something that is hereditary, type 2 diabetes, something that you is how you are raised to eat the food that you intake, and that what causes diabetes and what causes it to be so rampant?
Well, that's a multi-layered question. I'll take bits at a time. I love to hear of that, and it's strangely one of the first myths that I like to debunk, diabetes, sugar. Sugar to the body is like gas to a car. Have no gas in the car doesn't run. Every carbohydrate that you consume is broken down to the simplest carbohydrate called glucose. And you may reference glucose as sugar because it kind of is. We refer to sugar, but we may think of table sugar or high fructose corn syrup. But actually, everything on an ingredients label that ends in OSE breaks down to glucose, or could technically be considered sugar. That's fructose, glucose, lactose, maltose, any kind of ose. All of those break down to the simplest ose or carbohydrate in the body as a glucose, and that's the only way that the body uses glucose or a carbohydrate. Diabetes is not a sugar issue at all. It is actually an insulin deficiency issue. And in care, in my clinic, that's how we start. We start by changing that mindset. So, yes, you can have sugar. Yes, you can have carbohydrates. But what we want to do is just take in enough to match what our body can do to manage it. Diabetes is an insulin deficiency issue. Insulin comes from your pancreas. Your pancreas is your insulin maker. Not all of the pancreas, but certain cells in the pancreas. And you can't make your pancreas work or not work. It happens automatically. When you don't have diabetes, you can eat what you want to eat. You may get sick, you may gain weight, but your sugar won't be out of control. You can't eat yourself diabetic. Your pancreas works to keep the blood sugar under wraps when it works at 100%. At that moment, when you start to see higher blood sugar, it's a symptom of diabetes. High blood sugar is not diabetes. It's a symptom of diabetes. It's an indicator that the pancreas isn't making enough insulin to keep the blood sugar under control. So that's one. It's not a sugar problem. It's an insulin deficiency problem. The next thing you asked if it's hereditary or does it just come about because you eat yourself diabetic. You can't eat yourself diabetic because, again, the pancreas works on demand. Blood sugar goes up, insulin comes out. If the blood sugar's up and it stays up, that's evidence that the pancreas can't make enough insulin to keep the blood sugar in a safe range. It does have diabetes. It does have hereditary origins. However, you don't have to help out the risk by increasing your weight, keeping your blood pressure under control, keeping blood cholesterol under control, because those things contribute to the risk factors. You asked then about the way we eat. Well, it's, culture is a special thing. In the South, I'm in Tampa, Florida right now, but I'm from Columbus, Georgia. Around the stroke belt, which really goes from like Louisiana up to the Carolinas, people really don't eat that much differently. So we sort of see the same prevalence of diabetes in blacks and in whites that have similar phenotypes, big waistline, have high blood pressure, that have high cholesterol, get gout, that have issues getting pregnant, have 9-pound babies. You start to see this over age 45 and actually younger when those characteristics are posed in that 25 to 35 range. So it's one of the risk factors, heredity, but it does not mean that you will have diabetes, but the risk is increased when there is a family history. I think I answered all of it.
You sure did. So a couple questions I have. There's this thing, old saying that my aunt used to say is like, you can't be a little pregnant. You're pregnant or you're not. But I heard that you could be a little diabetic. We talk about pre-diabetes versus diabetes. So if you're a pre-diabetic, can you reverse your track on being diabetic by changing your health, how you eat, how you manage your blood pressure and other things that you talked about? Can you talk about pre-diabetes?
Absolutely. Like I said, diabetes is an epidemic, and every couple of years we get new statistics that come out on the CDC diabetes fact sheet. And currently, more than 37 million Americans have diabetes. And about a quarter of that total is unaware of their diagnosis. about 90 to 95% of the people with diabetes have type 2 diabetes. And though there's about maybe 13% of America that's African American, more than 14% of people with diabetes are African American. So that certainly is a risk factor there. You asked about pre-diabetes. Pre-diabetes is like being a little bit pregnant. So I love to say that, and I'm glad that you brought up that comparison. So again, diabetes is not a sugar problem; it's an insulin deficiency issue. So if blood sugar goes up, that's a symptom of diabetes. Insulin itself comes from the beta cells in your pancreas, a part of the pancreas. So if your blood sugar is higher than normal, that's evidence that the pancreas is not performing at 100%. Prediabetes means that your blood sugar has gone up, but not high enough to meet the threshold diagnosis. Okay? Prediabetes means that the blood sugar has gone up, but not high enough to meet threshold or criteria to check the box and say you have diabetes. Now, why should we be concerned about that? Glad you asked. People don't die of diabetes, they die of diabetes complications. And most of those complications are centered around adverse cardiovascular outcomes. That means heart attacks, strokes, and peripheral vascular disease, or poor circulations, or gangrenous issues, or clots in the legs, etc., things like that. So in that pre-diabetic phase, that's actually when we see lots of that. Sometimes people go to the hospital because of heart attacks, strokes, et cetera, and they find that their blood sugar is a little bit high, or they'll go for open heart surgery or some kind of cardiovascular repair issue, and they'll end up on insulin in the hospital, but not when they go home. And people wonder about that. I'm not diabetic. Why am I using insulin? Well, the body's under stress. You have to take medicines that quote unquote push your sugar up. Those things don't make you diabetic. It's just revealing that it was already there. That means that the conditions create blockages along those insulin receptors where the pancreas just isn't powerful enough to do the job. In prediabetes, we like to prevent that threshold from being met by reducing the body's need for insulin. In other words, we try and match the body's need for insulin with what the pancreas can output, the output of the pancreas. Kind of like budgeting. If you spend beyond your means, then bills get unpaid, your mortgage doesn't get paid, or your car gets repossessed, or whatever. So you start to live within your means to balance, what you do with your pocketbook. That's how we manage diabetes. You ask, could it be reversed? Well, the numbers will look better if your need for insulin matched your capacity to put out. The numbers, again, just reflect your body's ability to manage. So in that sense, can it be reversed? Your place on the continuum can be improved, meaning not going forward, the diabetes care continuum. So in that sense, yes. Does it change what your pancreas capacity is? Not really.
Okay. So from your perspective, dealing with patients every day, are you seeing an improvement in awareness in how we are handling our bodies and how we are treating ourselves?
I'd have to say that my practice is so yes, in the community that I serve, and I hope so across the nation. I can say that our awareness, has increased. What kind of outcomes have resulted from that? It varies per community, and it also varies by access to care, access to diabetes education, and access to the newer medications. The newer medications actually do a great deal to lower the risk of complications. And patients that have diabetes have big improvement in their quality of life when they use them. Speaking from my practice, I am a provider that looks for those early risks. For example, insulin resistance, as I mentioned, 90 to 95% of people with diabetes have type 2. Insulin resistance is a part of type 2 diabetes. We see slight glucose elevations or sugar elevations. We see slight blood pressure elevations, like around that 130, 85 range. We see higher triglyceride levels, lower good cholesterol, HDL level, and also waistlines in men greater than 40 inches and waistlines in women greater than 35 inches around the center, right around that belly button area. So any three of just those five criteria that I mentioned does indicate insulin resistance is there. So when I look at the objective information or the clinical data, your labs, way the patient presents, what they look like when they come, in the door, I pretty much can say you're diabetic or pre-diabetic. That's cardiovascular disease right there, just by looking, at patients, because the outside presentation reflects what's going on inside of the body, and that's what I start working on. When patients have more energy, when they losing weight, when their heart health is better, their kidney numbers look better, that's extremely encouraging. Providers that understand and approach metabolic disease, which is diabetes, heart disease, etc. When they approach the patient in this proactive manner, we do see a reversal. We do see activation of the patient when they are engaged to the point where they are anxious to come to the doctor. They're ready to come to the doctor. Say, look at my blood sugar numbers. Look how much weight I've lost. Look, I don't need this medicine. I am choosing. I had this much produce today. I had this many vegetables. I'm trying quinoa. They get excited about their palate changing, their desire to exercise and be more active, take in some sunshine, and decrease their medications when such is the case. But the provider has to be proactive, and the patient needs to know to ask the right questions when they go in for an office visit. So to answer your questions, my patients do phenomenal. My patients do. When I'm in the community and participating in platforms like this, I try and empower people to be a participating member of their healthcare engagement, not just a recipient of instruction, but go in with the expectation of some directions of living life the right way, and that every visit is going to take you closer to your goal of having better blood sugars, lower cardiovascular risk, an improvement of weight, and great quality of life.
So let me ask you this. It's clear that you have a passion for helping people with diabetes. What motivated you to go down this path?
Well, I've been fortunate to be, cross paths over the years. I just pretend to be 20, but I've been doing this for more than 20 years, actually. But when I was a registered nurse back in the 90s, I would always, and I worked in the hospital, I would always, see patients with diabetes, and they had questions about, why is this connected to I have a heart attack, and they say I have diabetes now. Why are they giving me with this? What happened to my toe? And if I, get off insulin, will my leg get better, my toe get better? Could I have, saved my toes if I wasn't on insulin? And the answer is actually probably weren't started on insulin, early, enough. But I didn't know those connections, and I kept getting those questions because, again, it's an epidemic. It's been an epidemic. We're just screening more and finding. Um, I couldn't answer those questions. So when I went back for my advanced degrees, that was like my undergraduate, my BSc. When I went for my MSc, I did my thesis on social support and health beliefs with in person who had type 2 diabetes. When I got my doctoral degree, I looked at type 2 diabetes and vitamin D in African American women. I had to have those questions answered. So it's a combination of having community inquiry, and I need to answer those questions, and the burgeoning epidemic, and I wanted to be able to answer, the questions that came to me as a result of the greater numbers in diabetes, and also being connected to some amazing mentors.
So, final question. If you could give people watching this, listening, 2 tips, 2 things to start themselves on a better path, 2 things that you would recommend.
Well, I'm going to give you 2.5.
Okay.
First and foremost, know your numbers. That means know where you are on the continuum of diabetes. Do you have diabetes? Do you have pre-diabetes? Do you have the risk factors, all the ingredients to make you pre-diabetic or diabetic, or do you have diabetes? This means, like, what are your triglycerides? What are your HDL numbers? What's your blood pressure? What is your blood sugar? What is your A1C? And that is the gold standard, a hallmark as to how well your diabetes is managed and how close you are to, or where you are on that continuum, how close you are to pre-diabetes, or close you are to meeting that threshold level of diagnosis. So first and foremost, know your numbers and your risk for diabetes. The second thing I recommend is just to be screened, get tested, get some information, be nosy about that status. Not just knowing your numbers, but we got to know what those numbers mean. We can't improve our cholesterol if we think we're doing awesome and making the same decisions over and over again. I had a patient, she has diabetes and perfect A1C, but I couldn't get the weight off. One of the tips that I gave to her is, for that last meal of the day, only have lean meat and a vegetable. Skip the starch for that last meal of the day, because you're just going to bed on it. Unless you're going to run a marathon after dinner, you're just going to store, that component of your meal. Found out she was eating fried chicken and baked beans. That was a meat. Beans grow. She didn't even consider, the sauce or the sugar.
The sugar, yeah.
That goes into,
Mm-hmm.
The baked beans, and then the batter or the crispiness on chicken. I don't even have enough grease in my house to fry anything. Just because I don't crave things like that. But that's not something that she considered. That was, the big piece of meat or the breast, and then something that grows, meat. So we worked on, what is lean meat and what is a vegetable. So meeting people where they are, and then for the people to find out, actually, or to assign meaning to, those numbers and to their risk factors. Having a more productive and participatory conversation with the healthcare provider. Those are the 2 tips. The last half that I want to throw in there is, watch these commercials. Listen to the TV. Listen to people that are in a community of influence, your family, professionally. There's more people with diabetes and at risk for diabetes than you can shake a stick at, than you can ever imagine. When you have these conversations, you learn things. It may not be advice, but it's something to begin a conversation. When you hear Ozempic on TV, and they tell you it can help your blood sugar, it can help you to lose weight, it can protect your heart, you take that question to your healthcare provider and say, hey, what about this? What does this mean? Is this for me? Am I a candidate for this medicine? I've had a stent placed. I've had, trouble losing weight, and they tell me that I'm pre-diabetic. Can I have this? Have that conversation with your healthcare. When you hear things like Jardiance or Farxiga and how it can help to prevent heart failure with you, listen and have, again, take these names and commercial, tips to your healthcare provider and have that conversation. Are you a candidate for these medicines? If your healthcare provider suggests metformin, ask your coworkers or someone in your family, what happened when you took metformin? Why does this, why is this medicine recommended for me to help me slow down and on the continuum or prevent me from crossing that threshold, meeting the criteria to have a diabetes diagnosis. Be nosy about your risk. Be nosy about things that come on TV regarding health, and know your numbers. Those are the tips that I.
Okay. So tell people where they can find you. I know you're in Tampa, Florida. We got people all over the country that's watching this. Out in Florida, where can they find you?
Well, Your Best You is located at 15511 North Florida Avenue, close to the Lutz line. And again, we are a full service primary care practice, and we do advanced specialized diabetes management with sensors and insulin pumps, multiple daily injections of insulin, and carbohydrate counting, and sensitivity factors, and non-insulin injectables, as well as weight loss, because these fabulous medicines have a tremendous effect on weight. So that's where you can physically find us. You can also find us web at ybyclinic.com, and also on Facebook, Your Best You Clinic. So I don't tweet much, but I have Your Best You 502 there. So you can reach out to us by any of those.
That's wonderful. Well, thank you so much for being the inaugural guest, Conversate with Us Radio. You know, I am a big fan of yours, and I had no doubt that you would bring the heat. Came to the knowledge about this epidemic that's affecting our community. Learn from this. Make sure you all check out Dr. Davis. Follow her on social media. And that's going to wrap up the first episode of Conversate with Us Radio. You can check us out on YouTube. You can follow us on Instagram, Conversate with Us. If you have any questions or comments on the show, leave it in the comments section. Make sure you give a thumbs up. Make sure you share this. Share this wonderful knowledge Dr. Davis just shared with us. Talk to you next time. Peace.